I'm opening. Good evening, ladies and gentlemen. On behalf of my colleagues in the organizing committee of the Pediatric Club, I would like to welcome all of you to this webinar. This webinar is CME accredited and it is conducted in collaboration with NMC Specialty Hospital, Dubai, and it is sponsored by Vita Biotics UAE. I would like to thank the country business manager of this company, Mr. Dr. Tawfiq Ali. If you allow me, I will share my screen. Well, is it okay, Ms. Fadi?
Yes, it's okay.
Yes,
Yes.
doctor. Yes, doctor.
Okay, once again, good evening, ladies and gentlemen. Our webinar today, the title is Pediatric Infectious Disease. Interesting cases will be presented by our speakers. Well, we have today eminent speakers, well known to everybody in Dubai and UAE. Dr. Walid Abu Hamu, Dr. Omi Narayanan. They are well known to everybody in pediatric circle. In a short while, I'll be introducing them. They are going to talk about interesting cases in pediatric infectious diseases. Well, as usual, we have a question. I would like to request our viewers to tell us who are these scientists and what are their contribution to the field of pediatric and infectious diseases. Well, you have a few minutes time. Dr. Tawfiq will announce the winner. Well, welcome to Dubai, one of the most beautiful cities in the world, and it's the best time to visit. Those who have not seen, we request them to come. A beautiful view of Sheikh Zayed Road and Burj Al Arab, the first 7-star hotel. Members of Dubai Pediatric Club in different conferences, on behalf of all of them, and on behalf of the organizing committee, I would like to welcome our viewers from all over the world once again to this webinar. In the organizing committee, myself, Dr. Joshi, the past president, Dr. Kalpana Sengupta, secretary of the club, Dr. Diari Muhammad, chairman of the academic affairs, Dr. Muhammad Amir Tolema, Dr. Ayman Jundi, Dr. Rafi Ovara, Dr. Srinivas Bandari, Dr. Leila Al-Bahri, and Dr. Khalid Rashid. Well, today, as I said, our webinar is about pediatric infectious disease. Our speaker, Dr. Walid Abu Hamu, Senior Consultant Pediatric Infectious Disease at Al Jalila Children's Hospital, Dubai, well known to all, and Dr. Omendra Narayan, better known as Dr. Omi, Consultant Pediatric Pulmonologist at American Hospital, Dubai. Well, we have our moderators, well known to all, Dr. Kalpana Sengupta, Senior Consultant Pediatrician and Head of the Department at NMC Specialty Hospital, Dubai, and Dr. Diari Muhammad, Senior Consultant Pediatric Surgeon at Al Jaila Children's Hospital, Dubai, well known to all. Well, next month on Friday, 2nd February, we will have a webinar entitled Sleep Disorders in Children. We will have eminent speaker and panelists. Our speaker is Dr. Muhammad Nami, and our panelists are Dr. Majid Al-Teneji and Dr. Omi Narayan, Dr. Omi. Well, details will be announced later. Well, our 10th annual Dubai Pediatric Club Conference will be on 19 and 20 April. We will have more than 80 faculty members. Detail will be announced. Well, our sponsor, Dr. Tawfiq, Country Business Manager of the Vita Biotics UAE. Well, briefly, in 5 minutes, I will give a brief account of pediatric infectious diseases, the history of pediatric infectious diseases. Well, always I present in the memory of Hippocrates, the father of medicine. Well, Razi is also considered the father of pediatrics. Razi was a 9th century physician who first described differences between measles and smallpox. Please note, in 9th century, measles was described. But today, just few days back, as of January 2024, public health officials have confirmed the spread of measles in Philadelphia community. So still we have problem with measles. So vaccinate all children with MMR vaccine. Well, everything starts with Hippocrates. Hippocrates said sepsis was first mentioned by writings in ancient Greece. The word sepsis comes from the Greek word sepo, which means I wrote. Hippocrates viewed sepsis as dangerous biological decay that could potentially occur in the body. So today, infectious disease and sepsis. Well, since ancient time, they have contributed to the history of pediatric and infectious disease. Hippocrates' description of a epidemic in the first book of epidemics, the description by Infectious, first century, of roundworm in children, pustules, and other problems. Orabicius of 4th century, writings on infant rashes, cough, coryza, draining ears, and psoriasis, that is inflammation of the brain. Aetius in 6th century, discussion of the fever, eye inflammation, sneezing, catarrh, and other problems. And please note here the works of Rhazes, 9th century, 9th to 10th century, who distinguished smallpox from the measles and noted the complication of the illness. And the 11th century works of the prominent physician Avicenna, better known as Ibn Sina, who wrote in children illnesses including tetanus, cough, catarrh, aphtha, and others. I'm not going to detail of that. Well, Robert Koch, in German, it is known as Robert Koch, the father of bacteriology, of infectious diseases. Robert Koch was the first to prove that a microorganism was the cause of an infectious disease. In 1878, he published a book which is described the pathogens behind the wound infection, called Investigations of Etiology of Wound Infections. And Theodor Ischerich, the first pediatric infectious disease physician, his landmark bacteriologic studies identified the common colon bacillus, now known as Escherichia coli, or E. coli, better known as. He was chairman of several prominent departments of pediatrics, including the Department of Pediatrics at the University of Vienna and St. Anna's Children's Hospital in Vienna, Austria. Arguably, you have the most prestigious pediatric position, just to know them. Well, how the pediatric infectious organization took place. The American Pediatric Society was established in 1888. The American Academy of Pediatrics was established in 1930. The Society for Pediatric Research in 1931 and American Board of Pediatrics in 1933 all contributed to the evolution of the discipline of pediatric infectious diseases. Well, initially, the Committee on Immunization Procedure was established in 1936, but joined to me as a chair. 3 years later, the committee name was changed again to the Committee on Immunization and Therapeutic Procedures for Acute Infectious Diseases. In 1953, it was modified again to the Committee on Control of Infectious Diseases, and in 1969, to the Committee on Infectious Diseases, the current name, although it is now most commonly referred to as Red Book Committee because they are publishing in a book which the cover is red. Well, I will ask the audience in 10 seconds to tell us who is this gentleman. Of course, he is Stanley Plotkin, but he is involved in production and the development of a vaccine. In 1977 and 1978, Stanley Plotkin of Philadelphia led the establishment of Pediatric Infectious Disease Club, which held its first election of officers in 1982-83. The club evolved into Pediatric Infectious Disease Society in 1984. Please note that the Infectious Disease Society of America was established in 1962, and a number of pediatric infectious disease specialists have served with distinction in this society organization. Well, the initial certifying examination in pediatric infectious diseases was offered in 1994, and Pediatric Infectious Disease Journal, the most prestigious journal. The journal was established in 1982 by George McCracken and John Nelson, very well-known pediatric infectious disease specialists, and became the official journal of the Pediatric Infectious Disease Society in 1995. Well, since today Dr. Omi is going to talk about the interesting cases, infectious diseases pertaining to the lungs, Robert Millens, a founding father of the field of pediatric pulmonology. Dr. Millen worked led to the understanding of pulmonary edema ventilation in infancy and childhood, lung mechanics, and community approach to the asthma, just to know him. Well, since today's talk is infectious disease and sepsis, this is by Queensland government said 50% of pediatric sepsis deaths occur in first 24 hours. Please note, take all infections seriously. And this is by Newcastle upon Tyne. This cartoon is, they're given the red flags. Think of sepsis. Suspected or proven infection plus one of the following: core temperature less than 36 or more than 38.5, increased respiratory rate, inappropriate tachycardia, altered mental state, and prolonged capillary refill. And with this, have a lower threshold of suspicion for patient younger than 3 months, chronic diseases, recent surgery, and immunocompromised patients. Well, I was seeing this cartoon that this child is sick. The mother say, "Oh dear, you have fever, I'll make chicken soup for you." Now here the chicken is hearing and she knows that she is going to be killed for this soup. He said, "What? Just give paracetamol." I was curious enough to go and see what is relation of chicken soup and fever. There were articles, chicken soup inhibit neutrophil chemotaxis in vitro, and chicken soup help solve the common symptoms of cold and flu. Well, our speakers, once again, Dr. Walid, consultant pediatric infectious disease at Al Jalila Children's Hospital, well known to us, and Dr. Omi, consultant pediatric pulmonologist at American Hospital, Dubai. Well, as I mentioned, sepsis kills in 24 hours. This is the Nobel Prize winner's quotation. Gabriela Mistral said, "Many of the things can wait. A child cannot. To him, we can't answer tomorrow. His name is today. So you have to decide today." My reference is beautiful Dubai, Sheikh Sayed Road, day and night. Thank you very much. Now I would like to request Dr. Omi to start his talk. Then Dr. Walid will start, then we will go for discussion. Dr. Omi, please.
Thank you very much, Dr. Saurabh. And thank you for inviting me to give a talk about infectious diseases. I hope the screen is visible and I'm audible. So I thought that I'll leave the tricky and more clever stuff for Dr. Walid to speak. I'll just restrict myself to pneumonia cases, and these are all from the last 2-3 weeks that I have picked up. As you all must be dealing now in current scenario, our ward is full of just pneumonia, various kind of cases, different presentations, but they all have pneumonia. So I just handpicked 3 of them from our current cohort, and I thought I'll just take it through. And then in the end, we'll talk about 1 or 2 take-home messages that I feel is important from this. So this is case 1. So this is an 8-year-old girl who has had persistent fever at the local district hospital, and that was the reason we were asked for help. So she had presented to a local hospital with cough and fever for a couple of days. She had a chest X-ray done with some initial blood workup, and that showed that she had bilateral pneumonia, particularly worse on the left side as visible on this X-ray, and some consolidation on the right side as well. She was appropriately admitted. At that stage, she was slightly hypoxic, needing, I think, 1 to 2 liters per minute of oxygen, was significantly tachypnic, and was started on intravenous antibiotics. Now, at that stage, she was not in any kind of septic looking child. So she was kept on the ward, didn't require any fluids. Now, the interesting thing for her was that despite giving IV ceftriaxone and clindamycin, which was initiated after our advice, because on this X-ray, the first X-ray itself, it looked like there is some fluid collection as well. And she had an ultrasound done next day that showed mild left-sided pleural effusion, as you can see on the screen, that it's non-loculated, clear pleural effusion, and very small quantity. So she was commenced on ceftriaxone and clindamycin to give a good cover for Staph aureus and Streptococcus, and she was continued. Now, subsequently, her fever persisted. Parents were getting worried that she is febrile, and when the fever persisted for 9 days, she was transferred to us, asking for help in terms of, does she have anything else? Are we missing anything? Or does she need any surgical intervention in terms of this fluid? Is it getting septated? Is the parapneumonic effusion turning into empyema? Although there was no evidence of this on the X-ray or the ultrasound. Now, I must emphasize, if we are looking for fluid and if we are looking for pleural effusion, empyema, the modality of choice for investigation is ultrasound, because that gives us the quantification of fluid, that tells us whether the fluid is septated or not, or is it clear looking. So she was transferred to us. At transfer, she was tachypnic at that time. She was still febrile. And I think, like any other parent, if your child has stayed for 10 days in the hospital, they do start getting worried. They start picking up the phone calls. They speak to every other relative in this whole planet asking for help. And so did these parents. They were nursing from background. They had some relatives in Australia who were giving advice from their end as well. Has this been done, that been done? So we were kind of just trying to reassure them that child is still not looking septic, but there were a lot of pressure in terms of what is the next step. So we did a CT scan. And as you can see on this CT scan, there was primarily bilateral consolidation. The fluid level was very small. There was some kind of air pocket there, and which could be that she was developing some early lung abscess inside the parenchyma. But the treatment was on the right side, on the right path. But because she was spiked in fever, we did some further workup done, and at that stage, she was able to give us some sputum sample, which we tested, and the sputum sample came positive for mycoplasma. And when we assessed her that time, she was clinically and audibly very wheezy. And the other interesting bit was that in daytime, she was looking very like good, comfortable chatting, many times saturating 9900 in just 1 to 2 liters per minute of oxygen. But nighttime, she would become very, very obstructive breathing. Her work of breathing was really bad, and she would require high flow oxygen at nighttime. So the picture was not kind of matching what's happening at nighttime and in daytime, because it was looking slightly different. But reassuringly, CT scan did show just bilateral consolidation, some fluid. So we changed the antibiotic at that time. So we started her on piptazocin. And we covered her for mycoplasma. So as you can see on the screen, the only thing that the pneumonia, so this is called as pneumonia panel, that you can do on sputum sample or on bronchoalveolar lavage, which is a PCR testing. Now, one of the questions commonly we get asked is that should we be doing serology for mycoplasma, or PCR is better? Now, serology can take some time for seroconversion for the antibodies to form. Second, it can stay positive for a long time as well. So if a child can give you a sputum sample, we always prefer a sputum sample that's quite sensitivity and specificity, both are high. And at our center, we do have the luxury of having a respiratory physiotherapist where we can also get induced sputum sample if they are unable to bring it out. So that definitely helps us to get a proper sampling which can be tested. So as I mentioned, the only positive growth in this child was mycoplasma, and other associated issues. She was very wheezy and more hypoxic and obstructive breathing at nighttime. So we ended up doing an oximetry as well on her overnight on intensive care, and as she was requiring high flow oxygen, that showed that she has obstructive breathing pattern, which is likely to be obstructive sleep apnea, because every time she was going in deep sleep, she was desaturating more. And with her ongoing pneumonia, bilateral consolidation, enlarged adenoids and tonsils, along with the possible viral infection, nothing was in her favor. So every time in nighttime she was sleeping, her illness looked significantly worse. So with her wheezing episodes, we also started her on some bronchodilators along with oral prednisolone to see if that would help her. She responded remarkably well, and in next 2 days' time, she was, in the first day itself, she started coming off her oxygen. She was feeling clinically better, and in 2 days' time, she was much, much better. On her labs, the interesting thing was that, as you can see on this lab, her markers in terms of white cell hemoglobin, they all looked okay. Nothing to be like really worried about. Platelet counts were looking okay as well. The one on the right is the first time when she came to us. On the left is after a few days' time. The only thing that was highlighting was that her eosinophil counts, the absolute eosinophil counts, were on the higher side. And we were slightly worried that, okay, if she is not responding, could there be some fungal element? Could there be some aspergillus? Or could there be any parasite which is going as well? So we did test her. We did some serology for aspergillus, which came as negative. We did do for parasite testing as well, and that was negative as well. So on this one, you can see that when she had presented, her CRP was on the higher side, 94, with her procalcitonin 0.6, which subsequently improved as she was getting better. So to summarize her treatment, first she was on ceftriaxone and clindamycin. As the fever persisted, we had changed the antibiotic to piptazocin and clindamycin. We continued. When the mycoplasma came, we added some clarithromycin, and when she was not responding, we changed the clarithromycin to levofloxacillin. And as she was wheezy, we tried her on some bronchodilators, which included prednisolone as anti-inflammatory. She improved significantly, and I reviewed her early this week. This was her pre-discharge X-ray. So as you know, the X-ray can take much longer period to show full recovery. So we do not need to keep repeating the X-rays. As she had bilateral changes, we wanted to see that the left lobe has re-expanded. And you can see just pre-discharge, she was doing significantly well. And she was off antibiotic when we have reviewed her in the last weekend. All antibiotics have been stopped. I have done some further allergy testing to ensure that if there is any reason for her eosinophilia. So we are going to do some spirometry with reversibility, and as her screening oximetry showed was abnormal, suggestive of some obstructive sleep apnea, we are going to do a full diagnostic polysomnography for her. So that was her first case. Coming to the second case, she was admitted at our hospital, and she was a 9-year-old, so similar age group. So first one was 10, she's 9, and she presented to us with ongoing fever and cough for more than 3 to 4 days. When she presented to us, we admitted her. This was her first X-ray showing some left-sided consolidation in the that's very obvious. We have lost the cardiac silhouette, but nothing that you'll be too excited about. Now, clinically, she was well in the sense that apart from fever, she didn't have any other respiratory distress. She was not requiring any oxygen. She was not looking septic. So we started her. We didn't have anything positive on her. First swab just showed us we did a respiratory viral panel that showed a rhinovirus or another virus. I'll just check. And along with that, again, she had mycoplasma. So she was again commenced. So that was her respiratory viral panel. As you can see, she had rhinovirus along with that mycoplasma and nothing else that was positive. On her blood, again, it was pretty unexciting. Her CRP was like 16, 28, white cells and things were pretty stable. So nothing on the bloods as well that was exciting. But the interesting bit for her was that she kept spiking fever, and she kept spiking fever for almost 10 days. Now, we do not like to send someone home if they're still spiking fever while you're on antibiotics and you're not too sure whether they're responding or they are going to develop one of the known complications of pneumonia, which could be parapneumonic effusion, could be empyema, could be lung abscess, pneumatoceles. So you are just worried that if they're still spiking fever, are they going into some kind of complication of pneumonia? So as at 10 days, she kept spiking fever. We did a CT scan again for her after 10 days. And by that stage, her consolidation was even much more pronounced. She had some mild pleural effusion on the left side. The right lung still looks pretty decent. There was not much going over there, but the left lung was getting much more organized, and there was small amount of pleural effusion. So 10 days of fever, we were still not too sure. Apart from mycoplasma, we didn't grow anything for her. We managed to get a sputum sample for her. And again, on sputum sample, on PCR, we just had mycoplasma. And when we grew that on culture, again, it didn't grow anything apart from mycoplasma. So initially, when she was admitted, she was treated with IV augmentin and clarithromycin. But on day 5, as she kept spiking fever, her augmentin was changed to piptazocin, and she was continued on clarithromycin as her sputum later came back as positive for mycoplasma. But when she was still spiking fever at day 9, we decided that we will change the the clarithromycin now because there is a possibility that she might have some resistance to resistant to treatment, her mycoplasma. So the only options, when, as you know, are either tetracyclines, which is doxycycline, or some fluoroquinolones, which could be ciprofloxacin, levofloxacin. Obviously, under 7-8 years age, we do not use any tetracyclines or any fluoroquinolones. She was 9. So previously, we had, in the last case, as I said, we had good response to levofloxacin. We started her on levofloxacin as well. But unfortunately, in this case, we did not see that improvement. She kept spiking fever for 12 days. At that stage, we did some additional blood workup to see, could this be resistance? One of the markers of resistance could be your high LDH. We checked her LDH, which was significantly high. So at that stage, we did discuss with our infectious disease team, and we started her on IV methylprednisolone for 3 days. And first time she became afebrile after 2 days. And after that, she remained afebrile. So she had a remarkable response to methylprednisolone high dose. So we gave her 3 milligram per kilo 3 times daily for 3 days. And then subsequently, we tapered her on 3 days of oral prednisolone. And she became afebrile. Day 14, day 16, she was discharged home. So just wanted to highlight, first case was mycoplasma, where we had to change from your normal clarithrol to leave some fluoroquinolones, and she responded. This case did not respond to that as well. There was some evidence that there might be some resistance going on with high LDH, and we gave systemic steroids, to which she responded significantly well. So as we know, in mycoplasma, when we're talking about mycoplasma pneumonia, sometimes it has no significance, even if you find on PCR. If you have something else, it could be even viral illness. But if that is the only thing that you're growing and they have ongoing changes, not responding to treatment, then we have to start thinking about, could this be anything else, or could this be a resistant mycoplasma? This is my final case, which is a 12-year-old girl, and she presented with 7-day history of cough and fever. She was seen in our emergency department before, and at that stage, we felt that this was a viral illness. That time, she didn't have any X-ray or any swabs done, and she was reassured and sent back for a review in 2 days' time. She came back in 2 days' time that she's still spiking fever, she's not feeling right, and she came up with some maculopapular rash on her body, and at that stage, she was not looking very well, and she had also had some puffiness in her hand and feet. Ongoing cough, fever, and some kind of systemic response. So we did a chest X-ray, and then she was she was admitted, and that showed, as you can see on the X-ray, there is some right-sided good-going pneumonia. She was productive. She gave us a sample that time. Given the fact that she was fitting into the criteria that this could be atypical, as well as she had progressively become worse. First, she was discharged on augmentin and azithromycin, but as she continued to spike fever, she was admitted in the hospital. These were some of her blood markers. Again, if you see over here, her CRP was slightly high. It was 150. But apart from that, platelet, again, stable. Hemoglobin, white cell count was on the lower side. And again, which we can see that in ongoing infections. But there was no evidence of sepsis or so. So she was productive. We managed to get a pneumonia panel on her sputum. And these are the organisms marked in red that you can see. So she grew Haemophilus, she grew Mycoplasma, and she grew Staphylococcus aureus. Now, along with that, we also saw that there is something, I don't know how well it projects on your screen, but it says MEC-AC detected. And when we look into MEC-AC, what does that mean? I'll explain to you, but it means that there is some resistant organism, particularly Staphylococcus aureus, which is resistant. So we are worried that this could be MRSA, which is like methicillin resistant Staph aureus. But given the fact that she was also presenting with some other atypical features of Mycoplasma pneumonia, particularly rashes on the body, maculopapular blanching rashes, that goes along with Mycoplasma pneumonia that we can see. So given the fact that she was, there was possibility of resistant Staph aureus, she was given some piptalocin and clindamycin. So when we are talking about resistant Staph aureus, then we have to think about what are the other things that we can use. Your possibilities are clindamycin, vancomycin, linezolid, or something like Septrin. So initially we started her on piptalocin and clindamycin, and she did extremely well. So this slide is just kind of explaining you the significance of MEC-AC. If you have on your panel, if you do a sputum PCR, and if you see this, that's what it's coding for. It's looking for some methicillin resistance. And if that is positive, then you have to think about that they will not respond to your normal penicillin, like augmentin, that commonly as first line we will be using. So we have to think about that the normal beta-lactamase inhibitors will not work, and we have to think what are the other antibiotics we can use that I mentioned previously. Now, sometime you will see that when you are doing your PCR, that's positive, but your sputum sample, when you send for culture, they might be negative. So we need to remember that the PCR testing, when we are doing on sputum, they are highly, highly sensitive and very, very specific as well. So because they will test even small numbers that will come as positive. So you have to correlate clinically. You would not be treating everything just because it has come positive. Some of them, they will even give you the quantification, whether it's 10 to the power 5, 4, 10 to the power 7, then you can quantify that, yes, whether it could be significant in your case or not. So you just do not jump on antibiotic just because your sputum PCR is positive for a bacteria. We have to remember the viral pneumonias are much more common than bacterial pneumonias. Mycoplasma pneumonia is not as common, but we have been seeing some resistance. And that's particularly in UAE, where we see a lot of travelers and we have a multi-ethnic population traveling from various places. So I looked into some data that do we have some data, where does this macrolide resistant mycoplasma come from? Now, the data from many of the Asian countries is lacking, but what is very obvious that in this South Pacific region, primarily like China, Japan, and then certain parts of Australia, is quite common in terms of macrolide resistant mycoplasma. So your normal azithromycin for 3 days or 7 days of clarithromycin is not going to work in these resistant cases. So how do you approach a refractory mycoplasma pneumonia? There are certain guidelines. It's not there in the BTS. BTS has been not updated. BTS stands for British Thoracic Society, not been updated for more than 10 years. And similarly, American Society has not updated for more than 10 years. So just looking into stepwise approach, and this is what we had done pretty much in our second case when she was not responding. So if you have a serology which is positive, or you're positive PCR and you do not have anything else, and you think that this child is behaving like mycoplasma pneumonia, then your first line treatment is macrolide, azithromycin 10 milligram per kilo for 3 days, or clarithromycin 10 to 15 milligram per kilo for 7 to 10 days. Erythromycin is not very commonly used because you have to use 4 to 6 times daily, which is not kind of feasible in children. The indicator, what you're looking for is persistent fever, or if clinically they go downhill. And if they have not responded in 3 days, then you have to start thinking, could there be some resistance? And that's what we were doing in our second case. She kept spiking fever for more than 10 days when we decided to change and think about something else. So first we had changed her from augmentin to piptazocin, and we continued on the clarithromycin, but then subsequently we added some fluoroquinolone, but she still kept spiking fever. And if you keep spiking fever for more than 7 days, then you have to think about resistance. And at that case, that time, you might consider doing some blood work in terms of LDH. If the LDH is high, then the recommendation is that there might be some autoimmune phenomenon going on, and you need to switch off the immune functions, and that's where the steroid comes in. And that's where you can give methylprednisolone 3 times daily for 3 days and look for, do they respond or not? If they respond, very good. If they do not respond, you can either increase the dose of methylprednisolone, or you might consider IVIG for 3 days. And that's what is the approach for resistant mycoplasma pneumonia in children. So just finishing off my talk by another, just last 2 slides. It's not always pneumonia, even if you're seeing that, okay, there looks like something is obvious. This X-ray was sent by one of our colleagues, kind of 15-year-old who was having some fever, but then suddenly passed out in the field while playing. This X-ray is very abnormal. History is not kind of classical, feeling tired and suddenly passing out, not a feature of pneumonia really. A CT scan was done on our advice, and that picked up that they have malignancy, a lymphoma. If they have unremitting fever, not responding, you would look for other causes as well, rather than just labeling that this could be pneumonia. We have to look for, could they have other infections like urinary tract infection? Do they have any joint involvement? Do they have other features of autoimmune? Do they have kidney involvement? Is the urine okay? Is it leaky? Could they, if the age group is right, could this be some autoimmune going on? Like we have seen a lot of Wegener's, which they will present like pneumonia, not responding to treatment. So what I'm saying is that if they're not responding, I wouldn't just keep going up and up, up and up, up, up on the antibiotics. I wouldn't just think of resistance, but I would be thinking about something else as well. Could there be something else going on? My final slide is this video where, in terms of a 15-year-old who's under my care with primary ciliary dyskinesia and known bronchiectasis, we tried all possible treatment of MRSA, but was unable to get rid of his MRSA and Pseudomonas aeruginosa. And he had bilateral nasal polyp, which was not responding to the medical treatment. And at that stage, we asked for ENT help to remove the polyps and see if that will help, because you quite commonly get colonized with MRSA and Pseudomonas in the nose. And this is the video being done from our ENT colleague. You can see this is inside the nose, inside the polyp. So much of pus just colonized with MRSA and Pseudomonas. So whatever treatment you do, if you're not removing it's sitting there, bacteria is there, you have to work. So this, whatever antibiotic you give, they're not going to work unless you do some cleaning. So that's my take-home message, that pneumonia is common. We know that is one of the commonest reason for hospital presentation. In fact, one of the commonest reason for childhood mortality as well in developing world. Resistant organisms are uncommon. If one of the crucial features that we are looking for is persistent fever, if they're hypoxic at presentation, that can be a bad prognosis. if the persistent fever is there, look for, are they developing any complications of pneumonia, or is it not just pneumonia and something else, or do they have resistant organisms? If you have the facility, try to get a sample. We rarely have to do a bronchoscopy to get sample, but yes, if they have some kind of malignancy, they are immune suppressed. In those children, we have a low threshold of doing bronchoscopy because they can get fungal infection very commonly. But if you have the possibility of doing sputum culture, pneumonia panel, that will help. And that's it. That's my presentation. Thank you.
Thank you very much, Dr. Omi, for excellent presentation of these interesting cases. I would like to request all viewers to write their question in Q&A box. After Dr. Waleed's presentation, we will have Q&A. And I would like to request Dr. Omi to stop sharing. And I would like to request Dr. Waleed. Our next speaker is Dr. Waleed, Senior Consultant, Pediatric Infectious Disease Medicine at Al Jalila Children's Hospital, Dubai, well known to all. Dr. Omi, could you please stop sharing? Oh, yeah, okay. Dr. Waleed, please.
Yeah.
Dr. Omi is so photogenic that I thought it is a slide.
No, I'm not sharing.
Yes, please. Dr. Waleed, please.
Yes,
Dr.
Dr.
Omi
Sarah.
looks like
What
Grammy
would you
Award
like to
winners
speak
today.
to? Share
Dr.
the slide.
Waleed, could you please share your screen, Dr. Waleed?
Yeah, okay.
Thank you.
It's okay, Dr. Sarah?
Yes, absolutely.
Okay. I can start?
Yes, please start.
Oh, okay. Assalamu alaikum. Good evening, everyone. I would like to thank you, Dr. Sohrab, personally for this tremendous work and continuous day and night working for our pediatric group in Dubai and community at large and even worldwide, enriching them with the very fascinating medical history, and always you are bringing very good topics to us. I would like to thank the executive organizing committee and also Dr. Diari and Kalpana, in addition to Mr. Tawfiq and Mr. Fadi. Actually, I enjoyed much the presentations of my dear friend, Dr. Omendra. Very fascinating cases. And these cases are eye-opener for everyone. And I would like to start with the last slide that Dr. Omendra mentioned, or his conclusion. I would like to tell you that really medicine has changed after the COVID-19 pandemic. No more we are seeing the most classical cases. This is one. We have to think out of the box. Changing and manipulating with the antibiotics is not the right way always, unless it is indicated. Pneumonia is not always bacterial infection or viral infection. It could be inflammation, it could be something else. So thank you, Dr. Omendra, for these nice challenging cases. And it raised also a lot of questions about these cases, very interesting cases. and the outcome very fascinating, you know, and all the infections or whatever they had resolved, which is the most important thing. Okay, again, I would like to present interesting cases here. First of all, disclosure, I have nothing to disclose. The first case, and again, you know, these are not straightforward cases. So for you and for my respected audience, think about it also, you know, and let me, what's your thought? This is 4-month-old female baby who was previously healthy. She was doing well 4 days prior to her presentation. Temperature 39. She had respiratory as well as GI symptoms, became hypoactive. So she was admitted to X hospital for 2 days and received oral azithromycin. Maybe they heard Dr. Omendra presentation and they started azithromycin. Child continued with spiking fever, which led her to our emergency department. And if you notice, Dr. Omendra, he emphasized, you know, continuous fever. This is alarming for the treating physician as well as concerning for the parents. Interesting, parents had respiratory infection a few weeks back upon their from Umrah. And so history is very important always. Again, as Dr. Amendra mentioned, you know, Dubai is the hub for the world. And so always we have to think about the travel history. Even if people residing in Dubai, you will not be surprised that a few weeks ago they traveled abroad and came back. So please, you know, always we have to ask about travel history. Physical examination was unremarkable apart from fever. Labs were okay, except you can see hemoglobin on the low side, platelet, the upper high normal. Interesting enough, C-reactive protein very high, PCT very high, ESR slightly high, but PCT almost 25. This is very alarming, and C-reactive protein 105 also really high. Labs, blood culture grew Klebsiella pneumonia. This is very interesting. So 4-month-old, previously healthy, you know, having respiratory symptoms, vomiting, diarrhea, and turned to be septic. Respiratory PCR panel was RSV positive. Again, this is another interesting finding. And this is another example to tell you sometimes it is really hard to say, you know, when they did the respiratory PCR and it came back positive for RSV, people will think this is RSV bronchiolitis and they will not proceed with other workup. However, very interesting because I would say some sort of protein or whatever they do, C-reactive protein and PCT. And this is, I think, indicated at this time, not at this time of the year, in the era we are living after COVID-19, because things, to be honest with you, have changed. Chest X-ray, it is not really that impressive. It goes with the RSV bronchiolitis. So my point, if chest X-ray done, RSV came back positive, clinically goes with RSV, radiological goes with RSV. If they had not done a C-reactive protein PCT, most probably they would not have done blood culture or started antibiotics. And if you look back to the American Academy of Pediatrics guidelines, it is no for RSV bronchiolitis. No chest X-ray, no blood culture, no blood gas, no inflammatory markers, supportive treatment. It fits this baby because he was not in respiratory distress, except for fever. These guidelines, because they claim that serious invasive blood bacterial infection almost close to zero. So it is not cost effective to do all these labs. However, she continued to have fever, again back to Dr. Amindra, the statement that I love the most in this presentation. What do you think? So now we have to think out of the box, We know it is a Klebsiella pneumonia, patients on right treatment, and fever continued. So I expanded the inflammatory markers, and the red flag here, it was the high PCR and PCT. So ferritin slightly high, LDH really high for 413, fibrinogen not high, ProPNB 1016, and I ordered COVID antibody because of the history. Parents were in Umrah and Saudi Arabia, and it came back positive. So I'm presenting this case because many take-home messages. If you think about this is just systemic inflammatory response syndrome, but with the RSV, usually we don't have this. With RSV bronchiolitis, very unlikely to have serious bacterial infection. Is it the COVID-19 that dysregulated the immune system and the patient has concurrent bacterial infection with MISC? All of these are question mark. However, the patient was improving, so I elected not to treat as MISC and elected to observe everything resolved. I did echocardiogram for this baby, and it was normal. I did follow-up echocardiogram, and it was normal. Okay, case 2, 8-month-old male infant, previously healthy. He was doing well till 10 days prior to his presentation to Al Jalila Children's Hospital. Started with fever and your eye symptom, productive cough. I don't know how 8 months he had productive cough. This is the and post-tussive emesis. Admitted initially to another hospital, RSV positive. Okay. Look, they did CBC and it was 24,000. And also, when I looked at the report, the limited inflammatory markers really high. He was given 4 days of ceftriaxone. Child continued to spike fever, so the family elected to be discharged and coming to Al Jalila Children's Hospital. Clinical examination was unremarkable apart from fever. Interesting, this is the chest X-ray. It is not really that impressive. It goes with the RSV bronchiolitis. But when we did CBC here at Al Jalila, the white blood cells 37,300. When they called me and the platelets 763, they called me at night. I said, just do expand the inflammatory markers for this baby and do COVID antibody also. And you can see here PCT was high, ESR high, the C-reactive protein high, platelets thrombocytosis. Baby continued to have fever, cultures negative blood and urine. So there was no bacterial infection. Respiratory panel again showed RSV in our hospital. COVID antibody and PCR negative. So the baby continued to have fever for more than almost 2 weeks of fever. With this systemic inflammatory response syndrome, I elected to treat him with IVIG, though it was surprising for the primary physician when I said give IVIG, which I agree with her because he was not really sick, but because of the fever, I said I would give him IVIG. She was very respectful physician, and she said, "Okay, Dr. Walid, I agree to give him IVIG if you say so." Look here, I repeated the lab, and it was almost 1,000, and LDH went up, fibrinogen went up, ProPNB 189, D-dimer 4.5. At this point, I recommended to give IVIG. So in 24 hours, there was no fever. I observed him for 48 hours and I discharged the baby, telling them to come 1 week in the clinic. And I repeated the lab for him. Interesting, the platelet went up to 1,385,000. Other parameter of the CBC was okay. ProPNB 76, ferritin went up to 900. Again, COVID-19, PCR, and antibody negative. I elected to repeat the echo for him, and interesting, there was dilatation of the right coronary artery, 3 millimeter with Z-score 4.5. Patient has G6P deficiency, so started on Plavix. Follow-up echo 2 weeks and 6 weeks, still showing no change in the dilated coronary. This is, I think, a very good teaching case for us. We are learning, and I'm glad I did give him the IVIG, and I followed echocardiogram in a week. Usually in 2 weeks and 6 weeks, but sometimes you have hunch feeling that, you know, I have to do it. And this is what happened with this baby, considering the prolonged fever, the high inflammatory markers, and also he is 8 months old boy. See, so I elected to do it, and alhamdulillah, I'm glad I did it. Case 3, 6 weeks old baby, born at term, previously healthy, admitted with cough and fever for 3 days, increased work of breathing, reduced feeding. All of these babies admitted this winter, you know, at the season of the RSV. On examination, vital signs, he had no fever, but because he was tachypnic, so he was admitted. Appearance looked sick in terms of respiratory symptoms and respiratory findings. He was tachycardic a little bit, but there was no murmur. He was retracting and wheezing. So typical of RSV, you know. CBG done for him, and it showed he was acidotic with PCO2 60, which is really, really high for this baby. Lactate was high, so baby was not going in the right direction. CBC is okay, platelets 5 500, almost 500,000. C-reactive protein not high. Procalcitonin was not really high. Respiratory panel, again, RSV. Again, if you pay attention to this Procal and CRP, I think they have indicated the value here. Most probably we are not dealing with serious bacterial infection. And this is typical chest X-ray for RSV bronchiolitis. Patients admitted initially to the floor because of deteriorating in the respiratory symptoms. He was transferred to the ICU because he required high flow nasal cannula. In the ICU, they repeated chest X-ray, and if you look here, there is, if you can see, like nematocele or yeah, this one. It was not there initially. If you remember the chest X-ray initially, there was right upper lobe pneumonia, but repeat chest X-ray showed this nematocele, which is really ominous sign radiologically in this patient. So in the ICU, given him cefuroxime, though I never use cefuroxime, but that's okay. It is not the most appropriate antibiotics for this baby. However, it can be given. After almost 6 days in the PICU, he was shifted to the floor, but again deteriorated, went back, and the chest X-ray showed pneumothorax. You can see it here. They did chest tube, and they took whatever they could take from the chest tube for culture, and started vancomycin and azocine. Cefuroxime was discontinued. A fluid culture showed MSSA, which is methicillin sensitive Staph aureus. They consulted me. I changed to fluoxetine. This is another example. We used not to see these RSV bronchiolitis with such invasive bacterial complications, to be honest with you. But things change after the pandemic of COVID. And so I think we have to relook and revisit our guidelines and how we approach, how we used to approach these kids presented with RSV or viral infections or pneumonias. This is another case. A 3-month-old boy, previously healthy, presented with high-grade fever for 3 days, reaching 39 Tmax associated with chills, cough, cold, and nasal congestion for 1 week prior to his presentation. He had GI manifestation also. Other review of system and remarkable. History of contact with the other sibling who was a twin, but girl. She had URI, upper respiratory tract symptoms 1 week before. And both of them, they had respiratory symptoms. They are twin, boy and girl. Past medical history, completely healthy baby. Completely healthy baby. Never admitted to any hospital. Never had any serious infection. Physical examination, patient looked dehydrated, pale, tired, tachycardiac, tachypneic, blood pressure is okay, maintaining, saturation 95, fever 39.2, capillary refill less than 2 seconds. So more or less he's reasonably stable on admission. Systemic examination, right-sided scattered crackles on the chest exam, heart, no murmur, abdomen, no hepatosplenomegaly. Other neurological other physical examination are remarkable. For the labs on admission, white blood cells 2.7, which is frank leukopenia, hemoglobin low also, and platelets normal. So again, the lab alarming here. A child 3 years old, previously healthy, respiratory infections and respiratory distress, but he has leukopenia and anemia. So it's something going on in the wrong direction. C-reactive protein 500, again, it is alarming. Procal 38. Procal 38.7. Respiratory panel influenza B. You know, before the pneumonia panel, as influenza B, this is not the typical lab results, to be honest with you, unless it is really more than influenza B. Pneumonia panel showed influenza B and Streptococcus pneumoniae. GI panel was negative. Inflammatory markers, LDH was very high, 1000. Ferritin. I did the systemic inflammatory markers when I saw this patient. Ferritin also really high, D-dimer high, fibrinogen slightly high. Interleukin 6, this is because he developed acute respiratory distress syndrome, respiratory failure. He was intubated, ventilated, and then pneumonia panel was taken from the aspirate. So when he developed these complications and respiratory distress syndrome, acute respiratory distress syndrome, ARDS, I did specifically interleukin 6, and you can see it's really almost 3000, normal less than 7. Pro-PNB 8000, which is really very high, ESR 51. Blood cultures growing Streptococcus pneumoniae, urine culture negative. So at this point, we have influenza 3 years old, healthy with influenza B, complicated with strep pneumonia, as well as septic shock or sepsis or severe sepsis, with severe respiratory inflammatory response syndrome, with multiple organ involvement or dysfunction. This is the chest X-ray. It showed bilateral pneumonic patches, right upper lobe and left lower lobe, obliteration of the left lower lobe also. And this is another X-ray when he was intubated. It was very stormy. And you can see here nematocele also seen in the upper and lower left side of the lung. He developed the pneumothorax on the right side. Getting worse day after day. I gave him IVIG and I started him on methylprednisolone, this patient. It is a long story to make it short. He required ECMO. He stayed on ECMO for almost 6 weeks. They took him from the ECMO. We could not clear his strep pneumonia from the lungs. Every time, you know, we do deep tracheal aspirate, frank pus coming and growing strep pneumo. Though it is not resistant, it is sensitive, pan-sensitive strep pneumo. But here there is what's called immune paralysis. The immune system shut down. So antibiotics by itself will not take care of this infection. So he was given IVIG. We gave him tocilizumab, particularly because of the interleukin-6 was high, and high doses methylprednisolone, and down the road we tapered it. They took him off the ECMO. He was hanging around for a while, then he required another set of ECMO, developed very bad, this is again, after they, even on ECMO, necrotic changes and frank pus coming from his lungs. He developed other sepsis, pseudomonas sepsis. He developed many different infections, pneumonia and sepsis, and finally fungal infection also.
Sorry,
So
Dr.
he
Walid,
required
3
another
minutes.
set of. Okay, he required another set of ECMO. Finally, took him off the ECMO another time, but he is really in very bad critical shape. So we are just treating whatever we could treat him, like ventilator support, treating the infection, prophylaxis, whatever we could do for this baby. Nothing else we could do for him. Again, it was very stormy course for this patient. Whatever we could do, we helped him, and this is the poor baby, hopefully, inshallah, he will recover. I don't know if I have another. Okay, I can stop here, Doctor. I can stop here. No need to continue. I prefer to leave the floor for the audience if they have other questions. Thank you so much.
Thank you very much, Dr. Walid, for excellent presentation and finishing in time. Now, I'd like to request our moderators, Dr. Kalpana Sengupta, Senior Consultant, Pediatrician and Head of Department at NMC Specialty Hospital, Dubai, and Secretary of the Club, and Dr. Diari Mohammed, Senior Consultant, Pediatric Surgeon at Al Jalila Children's Hospital, Dubai, and Chairman of the Academic Affairs to join and start the session. I would like to request Dr. Walid to stop sharing the screen.
Yeah, I stopped
And
sharing.
I would like to request Dr. Kalpana to start the session, please.
Thank
The
you,
screen,
Dr.
I stopped
Sohrab.
it. Huh? I stopped the screen.
No, it is still seen, Doctor.
You just stop sharing that red one. Press the red button on the top.
Well, I stopped it. I don't know. Fadi,
Red one on the top.
Fadi, can you stop the screen, if you don't mind? Yeah, I stopped the screen, Doctor. I'm not really that good in this, Where is Fadi?
Dr. Walid, on the top there is a red button, red, near the green red button. Yes.
Yeah,
Excellent.
you see, you are the expert. Without you, wallahi, I don't know what we could have done. Thank you.
Okay. Thank you, Dr. Walid.
Thanks.
First and foremost, I wish to thank both the speakers for really interesting cases and scary also at times. So this has really led to a lot of questions from the audience, and we will go through them one by one. If I can just classify, I think it looks like Dr. Omi presented cases related to mycoplasma or role of resistance of antibiotics to mycoplasma infection. And Dr. Walid opened our eyes to what could happen with RSV with so many complications. And yes, most of the pediatricians have been struggling over the winter with the similar issues. We will start by going through the cases actually one by one, because there have been, as the cases were being presented, lot of questions were being asked. So I would ask Dr. Omi first. In your first case that you presented, doctor, at the end of the treatment, do you feel that it was all due to mycoplasma?
That's a difficult question to answer, because whenever we are treating mycoplasma, I'm always taking it with a pinch of salt, because as you know, mycoplasma can be present and might not be causing any problem at all. And with PCR testing, even if there is probably one bacteria, will pick them up. So it's so sensitive. It's a highly sensitive. So that's why I was emphasizing that, just isolating an organism doesn't clinically correlate with having pneumonia. But if a child is not responding to your classical treatment for pneumonia, and you have an organism, you have radiological features, you have non-classical response to the classical treatment, then you have to start thinking that could there be something else? Would I be treating this mycoplasma now? Would I be treating with something else? But in parallel, we have to keep thinking that could this be something else going on? And that's what I've emphasized. So even now, retrospectively, I cannot say that was it 100% mycoplasma, but she responded well. And whether there was her symptoms were particularly worse with obstructive sleep apnea, and did the steroid help her to, reduce the size of adenoids at that stage, and that helped her to recover faster? Does she have some element of underlying asthma, which we have not diagnosed so far, and just a simple illness made her very wheezy and very, we don't know. So simple answer is very hard for me to say, was it just mycoplasma?
Yeah, of course, wheezing was part of her symptomatology, but she did have bilateral pneumonia, and which was very significant, and it did improve at the end of the treatment. So definitely the antibiotics did the job, whether it was only mycoplasma or mycoplasma with associated bacteria. We would not know. And your second case actually led to a lot of questions, especially because of the role of steroids.
Yeah.
So classical teaching, we withhold steroids when we are talking about infective pathology. And you did mention that it was due to resistance. Is it resistance or is it inflammation that we are targeting when we are using steroids? And under the umbrella of antibiotics, is it safe? So your comment from both of you would be good.
So from my perspective, when we are using steroid, there are certain things that I would personally prefer to know, that like, okay, that there is no immune suppression or some kind of malignancy that we will make it hide the symptom or make it worse with steroid. There is no fungus sitting there which can disseminate. And that's the only reservation we have. But in infections itself, you can use steroids. I mean, even with bad tonsillitis, you can use steroids and it reduces the inflammation. Now, I did give a clear protocol of, we use steroids on day 12 of fever. That was 12 days of fever, and there was nothing else which could have explained. We looked for other markers, and as one of the things that I suggested was we looked for LDH on day 12, and that was very high, which could be suggestive of resistant mycoplasma. Now, when we are saying about resistant mycoplasma, in that phase, you go into your host defense starts playing up. So you are not just using the steroid to suppress the resistance, but you are playing with the immunity to play with you want to suppress the host defense, and that's how it responds. So that's the role of steroids.
Naveed, what is your comment regarding this?
I'm sorry?
We would like you also to comment, doctor, on the role of steroids in such cases.
Oh, okay. To be honest with you, first of all, if we are dealing with mycoplasma pneumonia and all these cases, I agree with Dr. Amendra, you have to take it with a grain of salt when you say this is mycoplasma pneumonia. To be honest with you, my dear friend Dr. Amendra, I have never seen such complicated cases of mycoplasma pneumonia with such courses. The typical teaching for mycoplasma pneumonia, it is working pneumonia. X-ray might be not correlate with the clinical picture, clinically doing well, and that's why it's called walking pneumonia. However, as I mentioned, after COVID-19, we don't know what happened to infectious disease in general. Regarding the PCR, we know PCR, it might be lingering there for several weeks. So if we have PCR positive, does not mean necessarily this is an acute infection of mycoplasma. I agree with you, Dr. Amandra. The worst and the most cumbersome in the infectious disease investigation, the mycoplasma pneumonia. Serology, not really helpful. PCR, it is not really that helpful. They say the combination of both may be better for mycoplasma pneumonia, but I think we have to really, for your cases, I would have done the same thing, because the most important thing, patient improved and to go home. Whether it is mycoplasma pneumonia or not, this is another story. This is all of this just educated guesses that it could be resistant or not. But we have to remember the patients on other broad spectrum antibiotics covering other organisms. IgM, as you mentioned, Dr. Amandra, it might be for a month or so or 2 months positive. PCR, it might be for also 3 months positive in certain patients. So as you mentioned, again, for take-home message for our respected audience, that isolating positive PCR or organism, particularly in respiratory infections from the throat or from the sputum, does not mean this is the culprit for the infection.
And also,
regarding the steroid, I'm sorry, go ahead.
I was just adding that, like, when we are using for 2 weeks of meropenem and vancomycin, I'm worried about what it's doing to the kidneys, what's it doing to, other organs when we are giving such strong antibiotics. Are we looking into harmful effects of these antibiotics?
Absolutely, I agree with you. But again, to be honest with you, after COVID-19, we have to think of inflammation also, as well as infection. And the best case scenario, your case when you give steroid, and you put LDH between 2 brackets, it was really high. So we don't know about the other inflammatory markers, the broad spectrum of systemic inflammatory response syndrome. I had a similar case, 10 years old, admitted to Al Jalila Children's and Hospital, and I hope our residents listening to our webinar, because involved in this case, 10 days with all antibiotics, never responded. The fever continued to be there, and the pneumonia just consolidated lobe with no other complications. And they called me. I took good history, and the patient traveled to Germany and get COVID, I think, several weeks prior. I did the inflammatory markers, and they were sky high. I gave IgG. The next morning, she was febrile. I brought her, I repeated chest X-ray, gone. So I think we have to think at this time of after COVID-19, we have to think of inflammation and infection. This is my answer, Dr. Kalpana.
Thank you, Doctor.
Thank you.
And Dr. Diyari?
Yeah, good evening. Thank you,
Good
Dr. Omi and Dr. Walid. Thank you very much for this nice presentation. Dr. Omi, just regarding your first presentation, your first case. Now, 10 days on ceftriaxone and clindamycin, and continuously the patient having fever. So when you are thinking to after how many days of continuous fever, you are going to change the antibiotic?
It all depends on what antibiotics we have started with. As I said, our first line antibiotic for community acquired pneumonia is penicillin derivative, and generally comoxiclav is more than sufficient. And majority of times I would treat them for 5-7 days to see the response. Now, if they have had